The thing is, it's a very like artistic specialty, so there's a lot of like abstract thinking and like artistry that goes into it.
So have you ever thought about working in plastic surgery, wondering what it's like, what your hours are like, what kind of patients you see, what kind of autonomy you would have as a PA or NP? Today we're going to dive into that specialty. I'm joined by a former classmate.
Hi, I'm Michelle. I'm a plastic surgery PA, and I've been working in plastic surgery for the past 6 years since I graduated from PA school.
So if you're looking to transition into this specialty, or if you're a student and thinking about going into plastic surgery, stay tuned.
Hello. Welcome.
Thanks for joining us today. So let's dive in and talk about like what kind of plastic surgery you work in, because there's lots of different areas.
The bread and butter of what we do is breast reconstruction, and we also do a fair amount of cosmetic surgery. So, you know, your breast augmentations, your tummy tucks, your facelifts, stuff like that.
So you guys are mainly doing breast reconstruction surgery for cancer patients, I assume, right?
Yes. The other breast reconstruction that we've seen is when people have cosmetic surgery and have a problem.
Oh.
And then you have to go back and fix it, and it becomes a reconstructive case.
Right.
Unfortunately, that happens, but luckily we have ways to fix it.
Yeah. And these are, to be clear, these are people coming from other surgeons.
Yes, from other surgeons. A lot of times from another country.
Oh, okay.
So there's a lot more to plastic surgery than breast reconstructions. Okay. There's a lot of subspecialties. There's hand, and you can do facial reconstruction for like cancer cases or like injuries. And then like lower extremity reconstruction, that's like a whole almost specialty in and of itself. Limb salvage is what they call it. Right. So it's like the traumas, car accidents, like ATV accidents, open fractures. And then hand is really another like subspecialty in and of itself, which I don't have much experience in at all.
There's a lot of structures in the hand.
I've
always heard it's very, very specialized.
Yeah, it was like they generally, if a plastics person is going to go into hand, they do a fellowship in hand. Right. So they do more specialized training, and then that's what they do.
So did you know in PA school that you wanted to work in plastic surgery?
No. So if you told me in PA school that I would end up working in plastic surgery, I would have laughed and told you that was the last thing I would have gone into. I wanted to do OB-GYN, but after my OB-GYN rotation, I wasn't super in love with it because I really liked the operating room, and if you work in OB-GYN as a PA, you're really in clinic. You're not in the OR delivering babies. Yeah. So then I did my surgery rotations, and my last rotation of PA school was plastic surgery at MD Anderson, and that's really where I fell in love with it, and I was like, I want to do plastics.
And what made you fall in love with it?
So I really liked how much we got to do in the operating room. So we got a lot of autonomy in the OR. And then I liked that it was still women's health based because it was a lot of breast reconstruction. So it was very women's health heavy. And so those were the two big things that like drew me to it. The other thing is it's a very like artistic specialty. So there's a lot of like abstract thinking and like artistry that goes into it. And that's what I like to do, like hobbies-wise. Right. So it just kind of like meshed very well.
So I can see that from the surgeon side, but for the PA side, how does that come into play in your actual duties?
So like that's the art. Yeah, the art side. So if you're doing any kind of injectables like filler or Botox, okay, a lot of that requires a lot of finesse, and then being able to look and see like where you can put the filler to make it look to like optimize the result. Oh. So that requires like a discerning eye, and just kind of like a very high level of attention to detail. Right. And then the other thing is I do all of the 3D nipple and areola reconstruction. So I do the 3D tattoos.
Oh,
so
okay.
That is like completely.
Yeah, so you're like a tattoo artist.
Yeah. Yeah. So that's the other thing is like that is very artistic because you're like matching colors and like making sure it matches their skin tone and that it looks natural.
That's cool. I've heard about that before, but that's cool that you get to do that.
Mm-hmm.
So tell us a little bit about what your schedule is like on a weekly basis. How many days are you in the OR? How many days do you have clinic?
So we are in the OR 4 days a week, and we have clinic 1 day a week. On clinic days, we usually have about 40 patients. It's a mixture of new patients that are coming in for whatever, their cosmetic surgery, reconstruction, stuff like that. And then we have post-op patients that are like within a month post-op, and then we'll have like longer term follow-ups or patients that are ready for like their next step in their breast reconstruction.
How many patients do you personally see on like a clinic day normally? I know it varies.
So normally I see probably 30 out of the 40 patients.
Okay.
I don't usually go in the new patient consults because the doctor goes in and then we have our scheduler that goes in with him so that she knows what the plan is, so she knows how to schedule it.
The 3D tattooing, are you doing that here in the office?
Yes, that's an office
Is that
procedure.
on the clinic days too, or is that like scheduled as procedure and you do it on a different day?
Those usually get scheduled as procedures and are done separately, just because it takes me about an hour to do it.
So how many hours typically, like what time do you normally come in and leave on a clinic day?
On a clinic day, I'll probably get here at 7:45 and leave at 5:30, depending on the day and how caught up I am with charting.
Is the charting complex or is it pretty straightforward? Like, can you use a lot of templates?
I use a lot of templates, especially for the post-op notes, just to make it go faster. I have like a template that I just kind of have, like we use Epic, so I have like the dot phrases and then like the fill in the blank stuff, so I can just like click through it and change it.
Yes. So on the days that you're in the OR, what time do you typically come in and what time do you typically leave?
So the OR days, I come in usually between 7:30, depending on what time the case is starting. If it's an early case, it'll be earlier. And then some of our cases start later because we do combination cases, so there's another surgeon that's starting, so we don't have to come in before the case starts because they don't need us until later. So some of those I come in a little bit later. It just really depends on the day. And then we usually go until like 4 or 5 on OR days, depending. There are really big cases that we do that will go late, but we've gotten a lot better at them as time has gone on, so they've gotten a lot shorter than they used to be when I started. So now they end at a much more reasonable time than they used to.
Which is nice.
Which is good.
So what about charting on OR days? What kind of charting are you having to do?
So for OR days, I do like pre-op orders. So those are done in advance, so I usually do those the week before, 2 weeks before. And then I also put in like the history and physical for the surgery. And then the day of the surgery, I don't generally do any charting as far as like the op note or anything. Every now and then I'll put in a brief op note if I need to, if my attending tells me to.
Right.
But he has to do the dictation for the surgery, so he dictates all the procedures. And then I'll put in all their discharge information and discharge them. Okay. And then we've been sending in all their post-op medications either a few days before surgery or at their pre-op appointment, so they already have all their medicine at home before their surgery, so they're like set to go.
So most of the time when you're charting, you're actually charting for weeks coming up in advance instead of, there's some obviously on the patients that you're seeing that day.
Yeah, but it's not as much charting on surgery days. It's really just like orders.
Do you guys have call at all in the office?
So yes, we have call. We're on call, I guess it's like once every 5 weeks in theory, because there's 5 of us that share call. So it really hasn't been bad. And then it's really for the patient calls for our call center. And I assume this would be mainly just patients that have recently had surgery that have some question or problem with it. Yeah, so it's mostly patients that are calling because they're like missing a medication, they have questions about their medication, or they need, some of the clinics are open for like lab work on the weekend, so I've had patients call because they didn't have lab orders. So it's stuff like that. It's not
nothing too bad.
It's not terrible. And then we're not on call at the hospitals. the doctors are on call at the hospitals.
So do you see in plastic surgery that it's more PAs, more PA heavy, or more NP heavy, or a mixture, I would say?
So I would say plastics is more PA heavy, just because generally when they hire a mid-level in plastics, they want somebody that's going to help them in the OR, and NPs, unless they have their first assist, can't help in the OR. So generally it's more PAs, just because we can go everywhere and we don't require extra training to do anything. That being said, we have an NP that runs our clinic, so there's still opportunities. And then there are opportunities in plastics for people that are solely in clinic and don't go to the OR. So it just kind of depends on the job that you find.
Okay. So beyond the cases that you're in the OR working with the surgeon, what other kind of procedures do you do independently?
So I have done like minor procedures by myself. So like scalp cysts, lipomas, just like little procedures you can do in the office under local. A lot of the times when patients have a mastectomy, they lose their nipples. And so they can either have nipple reconstruction, where we like make a new nipple by like folding up skin, or if they have a normal breast on the other side, we can take part of their natural nipple and put it on their reconstructed breast.
I didn't know you could do that.
Yeah. Yeah, that one actually works the best out of all the options. So, and then there's some people that don't want nipple reconstruction, they just want a 3D tattoo. So I do the 3D tattoo, and that's a procedure that's done in the office under local. It gives them the appearance that something's there, but nothing's there. That's one of my favorite things to do, because a lot of people don't think it's going to make a difference. They're just like, yeah, I'll do it because it's like the last step or whatever. And then like when they leave after that first session, they're like, oh my gosh. And I've had people like start crying, and because it's like, you don't think it makes a difference, but it really does make a difference.
Yeah, so, mentally, like, to look as close to your normal self as you can.
Yeah.
That's cool. So you're tearing up.
Yeah.
There must have been a lot of special moments.
Yeah, I was like, that's just like those moments. That's why we do what we do.
Yeah, I can imagine it's very fulfilling to be able to help these women who have had, mastectomies and things, because for women it's such a part of our identity, right? And to be able to help them, again, that must be, is that one of your, I guess, your favorite thing about it?
Yeah.
What things do you dislike about plastic surgery?
We have difficult patients. There's some patients that just kind of have unrealistic expectations, and being able to manage those patients sometimes is a challenge. And then there's some patients that feel that like all of their cosmetic surgeries are very necessary when it's like elective, and they fail to understand that there's other people that have more pressing issues going on. So some of it, like, they can be very demanding, and that's just kind of one of the difficult things. But I think that's the same with any specialty. There's some people that are just want everything done as soon as possible, and just don't. There are institutional barriers, so it's like, we could fit you in tomorrow, but the hospital can't. So that kind of stuff, and so some of that stuff is difficult, is like managing all the moving parts, and then getting the patients to understand.
Do you deal a lot with people that have like body dysmorphic disorders that are trying to come in and have lots of plastic surgery, or is that pretty rare?
That's pretty rare. I don't know that we've had a whole lot of those, because we generally will tell people no. If we don't think we can make it better, then we're not going to do anything. Just because then you're only buying yourself more problems.
Right.
So yeah, it was like, if we don't feel like we can make it better, then we're not going to do anything at all. And then it is long hours, like in comparison to other things that you can do. A lot of it is long hours. But when I started, the hours were a lot longer than they are now. And we're not any less busy. I think we've just gotten better.
Right.
And so it's like, when I first started, he spent a lot of time teaching me. So my boss taught me how to operate. So he made sure that I like know basically how to operate. I'm not an assistant in the OR. I'm like helping him do the cases. So we can do a lot of things now in tandem, and that exponentially increases how fast you can do a case.
Right.
Versus like if I was just assisting him the whole time, he is the rate limiting factor.
Right.
Like it's only going to be as fast as he can go. Versus like if we can do things simultaneously,
right.
It makes it a lot better.
But it
takes a lot of time and a lot of pain to get to that point. So it's like there's a lot of there's long hours, and it's like there's a steep learning curve at the beginning. So both of you have to be okay with that part of it to get to like the shorter hours and cases going a lot smoother and a lot faster. But there is like at the beginning it's a lot more work.
Yeah. What was your first year like? Did you sometimes feel like quitting, or was it not that bad, but it was just long?
It was long. I don't think I ever felt like quitting. There were times when it was very overwhelming. But that being said, my boss is like a really good boss, so he really tried to like teach me and like help me.
You didn't feel like you're out there alone.
Yeah, I wasn't ever like out there alone, just like drowning and having no idea what I was doing.
Right.
And then the other thing is like I worked with residents, and a lot of the residents like to teach because they do a lot of teaching each other. So they were also a resource to like get you up to speed.
So it sounds like you had a fairly good experience with the supervising physician coming out of school, who liked to teach. Do you have any advice for people who are looking for a situation like that?
Generally speaking, if you look for jobs at the schools, like the medical schools, or a school that has a residency program, like Methodist has a residency program, so they have a plastics residency and then they have a general surgery, so those attendings are teaching usually. So if you look for kind of teaching institutions, you're more likely to get a physician that wants to teach. That's not always the case, but if that's really what you're looking for, that would be a place to start. I think bringing that up in an interview and saying that you want to be taught and that you want a learning experience, I think you can get that other places. Most of the physicians are okay teaching because again, it's like every surgeon does things differently and every surgeon wants things done their way. So they want somebody that's going to do it their way. So they don't really care what you know because it's not their way.
You feel like in general that this is a good job for new grads, like when they come out? Would you advise somebody if they're interested to go straight into plastic surgery if they can find a position? Or do you think, like if you had to do it again, do you think people should go work in family practice for like a year or so? Or do you think it's fine to come in as a new grad?
I think I would say come in as a new grad because unless you do it, you're not going to like start that learning curve. So it's just, you can have other experience and other things, but it doesn't replace like plastic surgery experience.
I know some people, say the pros and cons about going into specialty is that you might lose a lot of that medicine that you just learned in school before you had a chance to reinforce it. But you feel like you still get enough exposure to, you talked about needing to know the medicines and reviewing people's health before they go into surgery. So.
I feel like for the most part, the big things I can see on a regular basis. It may, like diabetes, I generally know like the management steps. I don't know the specific medicines per se, but it's like you can generally tell by looking at someone's meds like where they are on their like diabetes path. So I think you're still seeing some of it, but you're not managing it I also make a point to, when I do my CME, I pick stuff that's not about my specialty. I get enough surgery doing surgery. I need to know like the medicine stuff. So that's how I kind of like balance it out. Is like when you do your CME, pick stuff that you don't do on a regular basis so that you keep your exposure to that.
Yeah, that's smart. So this was your first job out of school, right? And how did you find the job, and was it hard to get hired if you didn't have experience or not?
So this was like one of the first jobs I applied for. It was not hard getting a job without experience. I think some surgical specialties are much more forgiving as far as not having like surgical experience, just because a lot of surgeons want things done their way. And when you hire somebody that is experienced, they already have habits that are somebody else's habits. So then there's a lot of like relearning, and habits are hard to break. So it's a little bit more difficult when you're already experienced in surgery. So it's like, it's a catch-22. So it just really depends on what how particular your surgeon is.
Do you feel like, though, that you need to have a plastic surgery rotation, or most PAs have at least general surgery rotation? I
don't think you necessarily have to have a plastic surgery rotation to work in plastic surgery. I think if you know how to sew, that's the biggest thing.
Okay.
That is it. If you don't know how to sew, it's going to be very difficult starting out, because you do a lot of sewing. There's a lot of sewing.
So if you are in school, or going into your rotations, try to find every opportunity, and if you're in family practice or the ER or wherever you have the opportunity to practice your suturing, to do that.
Yes.
Any other rotations that you think that would be really helpful for people to have if they want to get into plastic surgery?
I think primary care is helpful, just because you kind of know how diabetes is managed, how hypertension is managed, those kind of things, just because when you're pre-oping patients, you have an idea of how things are treated, what there's what's okay, what's not okay, that kind of stuff.
Right. Get more familiar with primary care medicines and those kind of things.
So you kind of, when you look at their medicines, you know what they are, what they do, and
right, any potential issues you have to watch out for.
Yeah, and then just kind of knowing what patients need more of a workup before they have surgery versus the ones that are pretty healthy and are good to go.
Right.
And then if you're in primary care, paying attention to breast cancer. If you're going to work in breast reconstruction, you should really know how breast cancer is treated and what the stages are and what the criteria are and what the treatment is generally. So it is helpful to have that knowledge.
Maybe even an oncology rotation if you have the chance.
Yeah, oncology would be helpful, especially if it's breast oncology, just because then you understand how breast cancer is managed, because how their breast cancer is managed determines how we approach their reconstruction.
Oh, okay. That's interesting.
In kind of the ER, the biggest thing would be doing any kind of laceration repair, just getting really good at suturing, understanding how to close the different layers correctly, the different sutures that you use, the rationale behind you using what suture you're using, triaging facial fractures or hand fractures. Dermatology is helpful, especially if you're doing Mohs and derm, because we do a lot of Mohs closures.
Oh, okay.
So some of the Mohs surgeons are very good and can do more complex closures than just a regular dermatologist. But any kind of skin cancer excisions, cyst excisions, lipoma excisions. It's just really knowing how to treat the skin. And then primary care would be similar with the lumps and bumps kind of thing. Right. If you're coming in with experience, I think it's helpful to come in with I know how to do some of these things, but how do you want me to do it? Right. Because that way you don't default to whatever you normally do. Just be how do you want it closed? What suture do you want to use? How do you normally close this? That way you learn what they want, because I mean, surgeons have a preference from like how the patient is positioned, how the drapes are done, how the patient's like toweled off, and then like suture, what blades they use, whether they use cautery or not, what kind of cautery they use, because they have like Bovie that has suction, and whether or not they like that. So it's just kind of like walking in like it's a whole new experience. So it's like, yes, I know how to close stuff and like how to do things, but how do you want me to do it?
Right, so you have to be willing to be flexible to do what the surgeon wants.
Yeah, so it's like, it's helpful. So it's like having experience is helpful, but then you also just have to take a step back and be like, but I need to learn what this surgeon wants.
So what about somebody that's been working for a while as a PA in, you know, some other, say they've been in family practice or they've been in emergency medicine, and they just really want to change, and they feel like that plastic surgery is, you know, what they would really like to get into. Any advice or thoughts on that?
It would just be talk to people that work in plastic surgery if you have contacts with anybody that already works in the specialty, because sometimes we know about jobs, or we can like point you in the right direction on that kind of stuff, or if you have questions about what we do, because there's so many different versions of the job in plastic surgery. So it's like everybody has a different experience, so I would talk to other people just so that you get a better idea of like what all the possibilities are. Because it's like there are jobs that are just clinic, there are jobs that where they're injectors and they just do filler and Botox and like cosmetic stuff, and that's all they do. And then there's people that work in the OR that solely work in the OR. They don't go to clinic. And then, so it's like there's so many different versions of the same job. So talk to people that work in it, and then just finding a doctor that's willing to teach you is, I think, the most important thing.
Thank you so much, Michelle, for joining us today and telling us all about plastic surgery. So if you're already working as a PA or an NP and you want to transition into another specialty, whether it's plastic surgery or a different specialty, and you want some ideas on how to go about doing that, how to find the jobs, how to prepare yourself for that specialty, I made a video on that, so I'll put the link to that down below, and I'll also put a link at the end of this video to take you directly there. Thanks for joining us, and see you next time on the Medicine Couch. Bye.